Two more areas I want to touch on before we part ways. One of them you recently touched on a little bit, but I want to go deeper into. And that was when you talked about the EGCG from green tea and that impacting glutamine. We've gone deep into the
Yeah.
GKI and approaching starving cancer from that aspect, but we need to make sure we acknowledge the glutamine piece too. And I asked Dr. Seafried when we were chatting one of the times if there was any natural way of controlling glutamine, and he didn't have one for me. His method is to use the pulse
Yeah.
of drugs to pulse that over time and to attack it that
Yeah.
way. What I'm getting at with all this, what other natural products besides the EGCG or different natural things we can do? Maybe it's exercise or who knows what. You'll know better than me. But what ways can we attack the glutamine naturally?
Yeah. I mean, a lot of work still remains to be done in this area. Just a couple things that come to mind. You know, creating a caloric deficit, preventing excess protein consumption. So just meeting your protein needs, but not eating beyond that. This will lower blood levels of glutamine. There's data, it's not super strong data, but I mean, there is data to show that EGCG extract can reduce glutamine to some extent. And then there are a couple. Of course, Dawn is one of the drugs that Dr. Seafried uses, and there's no doubt that Dawn is going to decrease glutamine use by the tumor. It's a very powerful glutamine antagonist. It does have some side effects. So a drug that I think that could be used, it's prescription, but does not have a whole lot of side effects. We've done some work in the lab, but not really. It's just more like cell-based assays. Another drug is sodium phenylbutyrate. So it's sold as buphenyl for urea cycle disorders. When you consume this drug, the metabolite conjugates with glutamine, and then you pee glutamine out. And then, you could look at various studies. It can knock glutamine down, I think, down to 30%. Maybe one study was 50%. But it's having a mild reduction of glutamine effect, and it's kind of dose related. The dosage does have to be a little bit high. It comes in a powder. I've taken it. I've done blood work. It didn't seem to alter, my comprehensive metabolic panel, liver or kidney function at all. I was curious of it. There was a study that was done in a glioblastoma patient at Moffitt, and I don't know whatever happened to the patient, but a glioblastoma patient used sodium phenylbutyrate, went into remission, and it was like there's like 5-year scans with no tumor. And it was the first author was Baker, and it was published in like 1999 or something. And I've tried to find this person or the team that did it, and they just went on. I guess they were doing the residency, but that got me very interested in sodium phenylbutyrate. So and I delved more into the research, and people have sent me 2 or 3 dozen papers on sodium phenylacetate. In mice, it's hard to use sodium phenylbutyrate because there's like an enzymatic deficiency that would prevent its therapeutic efficacy. But sodium phenylbutyrate also functions as a histone deacetylase inhibitor. And that was the reported mechanism, I think, in the Moffitt case report. So it's having a bunch of different effects. And just one of the effects that I found out later on was that it could lower, serum levels of glutamine. So that's one. And then the drug Dawn, I think, has a tremendous potential. And I just haven't been able to incorporate that into the research that we do, because I still want to nail down, and optimize the protocols that we're working on. Even the diet, I mean, taking a step back, I think we still have a lot to do in regards to optimizing the fatty acid composition of the diet, and optimizing the protein source and the needs, and optimizing the microbiome. But no doubt, for us to basically have the optimal approach to managing cancer, we do need to address the glutamine topic.
And when it comes to glutamine, how much do we need to knock that down? And how often? And again, this is
Yeah,
probably something that still needs to be researched and teased out. But in your opinion, how
yeah.
hard do you have to hit that?
This was discussed at a cancer conference. So if you bring this up among oncologists or cancer biologists, they would say, well, that's a bad idea. I mean, glutamine is given to cancer patients that undergo chemotherapy. Oral doses of glutamine help to restore gut function, and the delicate gastromucosal lining of the gut takes a big hit with chemotherapy. So typically cancer patients are given glutamine. It's a conditionally essential amino acid, and it's given to burn patients. So the vast majority of oncologists and cancer biologists will say you don't want to restrict glutamine. Glutamine's a really important amino acid, conditionally essential. When you get a burn, your immune system goes haywire to because you compromise your immune system when you break the skin open, and also when you undergo chemotherapy. So glutamine plays a very important role as a fuel that's important for preserving your immune system and immune function. And if you lower glutamine too much, then you're compromising your immune system, you're compromising your gut, and you're potentially altering different neurotransmitter systems and other you're weakening your body. So it's much like chemotherapy is taking a poison with the hopes that you're sparing your healthy cells to the degree that you can stay alive while you're killing the cancer cells. And I think the same thing can be said for these glutamine antagonists. They are toxic. Even drugs that we're interested in that target glucose, like 2-deoxyglucose. 2-deoxyglucose is a glycolytic inhibitor, 3-bromopyruvate, lonidamine. They inhibit hexokinase 2. They're remarkable drugs that we're able to kill. What's very interesting is that some of the early studies we did with brain tumor cells, and it would have been interesting to do Dawn with this, but we had brain tumor cells that we dropped the glucose level and we put in ketones, and then all the cancer cells would die. And if we had hippocampal neurons or cortex neurons and we dropped the glucose level and threw in ketones, the ketones would preserve the health, preserve the survival of the neurons. So it was a very dramatic demonstration. It replicated some of the work that was reported previously by a guy at University of Florida. And I just wanted to see if this was replicated, because I kind of didn't believe it. And it's like, wow, okay, cancer cells need glucose to survive. If you give them ketones, they die, in the absence of glucose. And that's not the case with primary dissociated neurons, at least in a petri dish. So there are drugs too that could kill the cancer cells. 2-deoxyglucose, lonidamine, 3-bromopyruvate. But much like Dawn, the dosage is going to be really important, right? With 2-deoxyglucose, it becomes cardiotoxic. Above 25 milligrams per kilogram, I think, is safe. It's actually used for epilepsy as a ketogenic diet in a pill. And I think it's kind of expensive drug, and as is lonidamine and some of the other ones. But I think of glutamine targeting and these glycolytic inhibitors as like the icing on the cake once you've nailed down everything else. So, you try everything else and you try to gently manage the tumor, but I feel that they have the real capacity to do more harm than good, much like radiation and chemo under certain conditions, right? So I think they need to be done. Well, more studies need to be done. A lot of studies have been done, actually. They're just not the big, RCTs that we need. But I think these things have potential, and I think they need to be used very cautiously. Cancer patients should not be finding these things on the internet and self-administering them. I think they need to work very closely with a doctor who has experience using them in patients.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
These are really important things that an oncologist is never going to tell the patient to do. Hyperglycemia and hyperinsulinemia is associated with much greater, sometimes